Yes. Now we're live. So some people take maybe 5 minutes to um, start connecting here. So we're gonna start some. I'm gonna start introducing you, okay, in three language, and then we start the discussion.
Sure.
All right. Um, let's me just double check here. Yes. All right. Okay. Thank you so much, Aaron. I'd like to um, give you a special thanks because uh, I know that you're so busy and talk to us about some specific points about Latinosis is very important because, in my opinion, in Europe, this preservation talks and these preservation concepts are are more frequent, but here in Latin America, I think it's quite new for a lot of surgeons. And we've been talking about this here in Brazil, but every place I go, people ask me how to apply that in our Latinos, in thick skin patients, and that's maybe a challenge. So it will be, I'm sure it's going to be awesome because you have a lot of experience. You live in South of California, and I follow you on Instagram. You're amazing cases. I think it's going to be perfect.
Yeah, thanks. Thanks for having me. I'm glad to be here, and I'll share whatever I can and answer any questions that I can.
Great, thank you. Entonces, en español, gracias a todos amigos de Latinoamérica. Yo sé que hay personas desde México hasta Chile, Argentina, que son muy interesadas en la cirugía de la nariz. A todos nosotros sabemos que es una cirugía muy difícil, es un desafío para cualquier cirujano que sea. Y la cirugía de la nariz latina tiene algunos puntos muy específicos, como el cartílago que no es muy fuerte, a la piel que es gruesa, entonces hay que hacer un tratamiento especial para la piel desde antes de la cirugía, en la cirugía, cómo hacer una buena estructura para esto, combinando con la cirugía de preservación. Entonces, muchas gracias a todas las personas de Latinoamérica. E em português também, obrigado a todos os amigos do Brasil. Sabemos aí que o Brasil é muita gente apaixonada pela cirurgia de nariz e é muito legal ter o Dr. Aaron hoje conosco, que é um cirurgião americano lá da Califórnia, casado com uma brasileira também, né, com uma descendente de brasileira, então ele fala português e muito interessante ele mostrar a experiência dele nos narizes latinos, que sem dúvida alguma são conceitos importantes que a gente vai poder usar nos nossos próprios casos aqui no Brasil. All right, thank you so much, Aaron. So let's talk a little bit. You were trained in the United States. I know that you recently you were giving some talks in Dallas Rhinoplasty, which is a really structured plastic course, and you went there and you gave some lectures about preservation rhinoplasty. And in United States, last time I talked to you, you said that there were just a few surgeons doing preservation rhinoplasty. So why do you think people are a little bit concerned about this changing in the philosophy of rhinoplasty in the United States?
Well, I think there's a couple things. Number one, there's rhinoplasty politics everywhere, and people that are very active in our society are people that have been at the forefront of structural rhinoplasty, which in ways is the gold standard. When I started presenting preservation rhinoplasty concepts 3 or 4 years ago in the United States, it wasn't very well received because it wasn't understood. People didn't know what I was doing. Before that, I brought piezo surgery to the United States, and it was the same thing. People were very apprehensive. They didn't understand it. It was different than what they had been taught. So, I think any time that something's different, people are a little wary, and that's okay. My opinion is that rhinoplasty and all plastic surgery gets better when you step outside your comfort zone, and I like doing that. But for a lot of surgeons, they don't like to do that. So, that would be my inclination. Also, the Dallas rhinoplasty course is a structural rhinoplasty course. The facial plastic surgery world with Dean Toriumi and Rick Davis, who are phenomenal surgeons, they're structural rhinoplasty surgeons. So, that those are kind of the pioneers and the people that are teaching a lot of the younger generations. So that's why preservation has probably taken a long time to catch on.
Yes, and for you, because you trained with Dr. Rolling Daniel, at least in part of your training, and Dr. Rolling Daniel is also an amazing surgeon, very famous and very popular. One of the first guys to talk about structural rhinoplasty in the world, and so your base was structural rhinoplasty. How was this transition for you? How was the new concept, and how did you deal with the incorporation of preservation concepts in your practice?
Well, I think it's important to understand, even though Roland Daniel was a structural rhinoplasty surgeon, you have to understand that he has a very different philosophy. If you look at least in the United States, and actually most of the master rhinoplasty surgeons in the world, they tend to define and perfect an operation. And they do that operation 95% of it in every patient. That's not how Roland Daniel was, and that's not how I was taught. Roland Daniel was a master of analysis, and then based on nasal analysis would largely adjust his operation. So in Bergamo, every year he gives a talk, which is 10 consecutive rhinoplasties, and he shows 10 consecutive patients that he does and the techniques and their 1-year result. And what he's demonstrating is that in the 10 patients, he did very different surgeries. I feel the same way. Anytime I look at something, I try and think about how it's going to make my life easier and how it's going to make rhinoplasty simpler. So when, for example, with dorsal preservation, when I started hearing about it from Yves Saban 4 or 5 years ago, it just occurred to me that could make surgery much easier. So it made sense to me. When Barish introduced subpericondrial dissection with preservation of ligaments in Newport Beach to me 8 years ago, it made sense. So it was something that I thought I might want to incorporate. So anytime if you see me at a meeting or if you see Roland Daniel at a meeting, I'm listening to everybody's talks, even if they're a medical student or a resident, because there's always something new to learn. And I'm constantly slightly shifting how I do things and then follow them.
Yeah, that's amazing. I have a brief story here to tell. When I finished my training back in 2009, and in 2010 I went to Turkey to do my clinical with Dr. Nazim. And on that time was the first time I heard about Dr. Roland Daniel. And what surprised me is that Dr. Nazim on that time was so happy and so honored, because one of the most top and famous rhinoplasty surgeons in the United States was about to visit him to see some new things that he was doing in subpericondrial dissection on the dorsum. So on that time, I stopped and I was thinking, wow, this surgeon, if he's one of the top guys in the United States and he's leaving his comfort zone in the United States to go to Turkey to learn something new, he's different. He's a different person and a different guy. So on that time, I was already a big fan of Dr. Roland Daniel.
Yeah, Nazim Circus is another surgeon where if you watch him give a talk, irregardless of what he's talking about, he typically gives 50% of the talk discussing analysis of the problem. And so Nazi Circus is another person who, depending on the problem, is really varying his operation. So, you know, some of us do every surgery a little bit differently, and some of us tend to do one operation on the masses. And it's not right or wrong, it's just it's your comfort zone.
Yeah, that's right. So what were your biggest challenges when you started preservation?
Well, there's three parts of preservation rhinoplasty. With preservation of the soft tissue envelope, it was just used to dissecting in a subpericondral plane and understanding the ligaments, how they work. This has all been made a lot easier because of the work of Peter Palhazy. Him and Yves Saban's description of nasal anatomy and of the dorsum and of the tip and the ligaments have really made a lot of this a lot easier. We have a much better standing of anatomy. With preservation of the lateral crura, the only difficulty in that was getting over the fact that most people have always been taught that if you remove volume from the lateral crura, the skin will somehow silhouette around that new structure and give you a prettier tip shape, which, as you know, isn't always true, especially in a Latin patient. That doesn't work at all. With dorsal preservation, I think the most difficult part was the fact that the only person I knew that was doing it was Yves Saban, and I had nobody to go and watch. So I had to figure out the surgery myself, doing it live in my patients. Now you don't need to do that. There's lots of descriptions and books and videos, but you know, I did my first dorsal preservation in maybe June of 2016 or maybe July. So, you know, we really had to figure out these operations, and you're operating in an area where when you're using an L-strut philosophy, you're not supposed to go. And I think that was the most difficult thing, was going into that area and then really loosening the whole nose. And just, you know, again, I just had no experience with that. I had nobody to watch. I didn't completely understand the anatomy at the time. So it was just, it was a difficult thing to just bring myself to do. I mean, to this day, I've still never seen another surgeon do a low strip dorsal preservation. I do them all the time. I was supposed to go visit Valerio, but coronavirus happened, so I didn't get to go do that. But, you know, I've done hundreds of them now, but all of these procedures I had to kind of figure out on my own. So that just made things more difficult.
Yes. And yes, in talking a little bit about tip, and also already introducing our discussion about Latinosis. When we study all this, a little bit, some of my thoughts. When we do structural rhinoplasty, we tend to trust on our septal extension graft, and but when we go to the philosophy of preserving everything without doing the septal extension graft, we trust on some ligaments and some soft tissue. We dissect less, and the first time, at least in my case, when I tried to apply that in some of my noses here, because in Brazil it's just like here in the United States, we have a lot of variety of patients. I had some loss of projection and loss of tip rotation. Did that happen also with you on your first cases when you were like excited with the technique?
Well, so I came at it a little bit differently. Roland Daniel always used a columella strut, and I used that in 95% of my patients in the first 3 years of my practice. And I was constantly disappointed by loss of projection, because if you lose even 1-2 millimeters, it really ruins a tip result. And me and Dr. Daniel are very tip centric. For me, the most important part of the rhinoplasty is the tip. I know dorsal preservation is all the rage, but the tip is where for me, is the most fun part of the surgery and where I see the biggest change usually. So losing projection is a problem. And the thing about the Latin nose is that it is more often than not underprojected. And not only is it under projection, the place that it really is underprojected is in the intrinsic tip, in the domes. So if you try and use a strut and ligaments, you don't gain projection. You maintain projection, but most Latin noses have a short lateral crura. So if you steal, you don't gain projection. You just rotate the nose and lengthen the infralabial, which if you look at most Latin noses, the infralabial is at a 90-degree angle. So if you steal, you make this even worse. It looks horrible. So for me, a columellar strut and lateral crural steal and relying on just Patagian scroll ligaments, in over probably 80% of patients, you can do it and your result will be good. But if you're really going, in my opinion, for an excellent defined result that's going to last the test of time, you need to increase chip projection centrally and tension laterally. And you can use preservation techniques to do this, but you can't rely on the ligaments in the strut and expect to see the same kind of definition. In my opinion, it just doesn't work.
All right. And you do it mostly open, is that correct?
In Latin patients?
Yeah.
Yeah, and again, it's because I think you have to. Closed rhinoplasty works best in patients where you're doing a reduction rhinoplasty of an overprojected nose. That's where it works really, really well. If you have an underprojected nose or an adequately projected nose with weak cartilage and thick skin, if you do a closed rhinoplasty, again, you can get a reasonable result, but it's just not, it's not my aesthetic. It's not what I like. The patients that come to me might be Latin, but they want Caucasian definition. And you just can't get that doing the same type of surgery. It just doesn't work the same. You really need to tension the cartilage against the soft tissue envelope. And that best occurs by increasing projection in most patients that are Latin.
All right. And you first talking about the skin in Latinosis, you have also a lot of experience because you work with Dr. Obagi, I think, right? And you have a lot of experience with some dermatological treatments and also wrote an article about the treatment of thick skin patients. So tell us a little bit about your protocol in Latinosis with thick skin patients for the treatment of the skin.
So surgically, in the operating room, again, it's increased projection, tensioning, and debulking the SMAS layer, which you can only do effectively open. And then you use the ligaments not to maintain projection, but to close dead space. Preoperatively, if people have thick skin, it can come from two issues. One is thick dermis, and two is thick subcutaneous tissue. Thick subcutaneous tissue, or SMAS, that's debulked surgically. But if someone has thick dermis, this is something that you can affect before and after surgery by controlling oil. Oil glands live in the dermis, so if you shrink the dermis, you shrink the skin, and that's done by shrinking the oil glands. The best way to do that topically is with salicylic acid, mandelic acid, glycolic acid. These things all control oil, exfoliate the skin. So does retinoic acid. Orally, I also like to use isotretinoin or Accutane in patients that have bad acne, rosacea, sebaceous gland hyperplasia, which just means large pores, or thick dermis. And you can tell the difference by ultrasounding your patients. If I do that, I use Accutane starting 3 weeks after surgery, 20 milligrams for 5 months. But you need to keep using the topical treatment indefinitely. Otherwise, the oil glands will grow back, the skin becomes re-inflamed, and it starts the process all over again.
All right. So you keep the topical treatment forever.
If a patient has oily skin or they have rosacea, which is a disease of oil, it's not going to go away until the women go through menopause and lose their ability to make hormones. So if they have that type of skin, it's a lifelong issue. So you've got to treat it just like high cholesterol. You know, it's not just going to get better. The liver makes too much cholesterol.
Yeah, yeah, great. Um, and how about the dorsum? Sometimes the dorsums are already a little bit wide, right? And in some cases where we choose, for example, Saban's technique, it could be a little bit wider, especially in Latinosis. In what is your rate nowadays between Saban's technique and SP2R for this kind of Latinosis?
You know, for Latin noses, so there's 4 types of dorsal preservation. 2 of them are surface techniques, and 2 of them are impaction techniques, which include the high strip and the low strip. But
Yeah,
you know, Latin patients, a lot of them don't do well with impaction, and the reason is most of them have S-shaped nasal bones. Most of them have a low radix, and most of them have a small hump. So you're doing a really big impaction surgery on a group of people that have usually a small problem, a smaller hump, a low radix, and S-shaped nasal bone. This isn't optimal. The
yeah,
best procedure to do on these people, in my opinion, are the cartilage pushdown techniques, with or without maintaining the bone cap. And the reason is you're converting an S-shaped bone to a V-shaped bone, right? So you're taking away the convexity of the bony cap, you're
yeah,
separating it and dropping the cartilage. Then you can deal with the bones separately by doing osteotomies. When you do that, because you're not impacting the nose, there's no radix osteotomy, so you don't lower the radix. You're
yeah,
also solving the S-shaped nasal bone problem. You're also solving the wide nasal bone problem. And if the patient has a wide nose, if you use a high strip cartilage pushdown open, I actually sew the vault back down to the subdorsal septum in 4 different places so you can modify the width. So
okay,
for Latin patients, I would say that I do dorsal preservation 50% of the time. And of that 50%, probably 80% are a cartilage preservation technique, not a impaction technique.
all right, great.
If
And
you, if you have S-shaped nasal bones, you're not going to be happy with your surgery. You're going to have residual humps. You're going to drop the radix too much. They're very difficult vaults to flex.
okay, and do you use piezo in 100% of your osteotomies?
100% in every patient over the last 7 years, except there are 15% of patients when I do an impaction technique, I don't dissect the skin off the dorsum. And in that case, I'm using osteotomes because I haven't lifted the skin, so I can't use piezo. Or if I do the surgery closed, which I do in about 10% of patients, then I don't use piezo.
All right. And what are the main advantage that you think for using piezo?
That's easy. Especially, listen, if you've been doing rhinoplasty for 25 years and you're great with osteotomies, that's fine.
Yeah,
But I wanted to shorten my learning curve and become a lot more predictable, reliable, and accurate. Piezo surgery is the way because number one, you expose the whole bony pyramid so you can see what you're doing. That's number one. Number two, the instruments are much more accurate because you can see what you're doing and you're making the cuts in real time, and you don't get this icebreaker effect that you get with osteotomes. And number three, you can treat asymmetries, and every bony vault is asymmetric. The lateral bony wall is more convex on one side, it's more vertical on one side, so you can vary your osteotomy patterns depending on the nose. We wrote a couple articles on piezo surgery, but on the second one, we make a really big deal about the difference between V-shaped osteotomies and U-shaped osteotomies. Also, you can drill holes in the bone and you can hold them where you want. So all of these things are important. And I remember I was giving a talk in the United States on piezo surgery, and 4 other panelists gave talks on osteotomies, and they all said, well, I don't need piezo surgery. My osteotomies are just fine. But I can tell you, if you looked at the dorsal aesthetic lines in every one of those surgeons' before and after photos, their bones were not perfect. So there's always room for improvement, and anything that makes your life easier and more predictable. You know, rhinoplasty is just about avoiding a complication, avoiding a bad result. That's all of rhinoplasty. So anything that helps you to do that is helpful.
Yeah, for sure. Yeah, and every thing that technology can improve your our practice is welcome. So Piso, I think it's one of these tools that may make our life easier, especially in some selected cases. At least in my case, I already use it. I thought it was really nice, especially in asymmetric bones. But definitely I should work more on that to improve it in my routine, to put it in my routine. Um, so Aaron, you selected some cases, right? So we're talking here a lot about how to deal with the skin, and also to push the skin with the structure of cartilage and dorsal preservation. But maybe if you could show us some cases, we could understand even better what you're saying.
I'll show you 2 Latin patients where I did dorsal preservation and I did structural tip surgery, which is very common when I do patients Latin. So
Great.
can you tell me if you can see this?
Yes, we can see that.
Okay. So, you know, I think analysis is very important. This is a 24-year-old female. She's typical patient that you'll see from the southern part of Mexico.
Okay.
These are kind of this is her front and side view, and then her 3/4 view and her basal view.
All right.
And so an analysis, you know, she's from the Jalisco part of Mexico. We're fortunate in that she's got thin to medium skin, but she's got her dorsal aesthetic lines are beautiful, but for me, they're a little bit narrow. If you want to fit this tip to those dorsal aesthetic lines, you're going to make a very skinny, narrow, unnatural nose. So this is someone where widening the dorsal aesthetic lines in the middle vault is actually advantageous. She's got a lot of infralobular show and a bulbous tip. She's got a dorsal hump, columellar show, and caudal excess with lack of that rim highlight that Dr. Checker talks about. So her hump is actually a V-shaped hump. She's got, remember when I was saying that they have that 90-degree turn of their infralobule? I want you to imagine what would happen to this nose if you did a lateral crural steal on her. That infralobule would bend back even more and look awful. She's got a mostly cartilaginous nose. Her total projection is appropriate, but her not over projected, and she has too little intrinsic projection. Her rotation is appropriate, her tip rotation, her nostril rotation, and her columellar inclination. She's got caudal septal deviation, fairly nice symmetry of the nasal nostril sidewalls, and good nostril support. So for her, I'm going to do a full open approach for piezo surgery, total subpericondrial, subperiosteal exposure, a high strip letdown of the dorsum with piezo osteotomies, alar rim flap, 1.5 millimeter caudal trim, a septal extension graft, cranial tip sutures with a 2 millimeter lateral steel and preservation of ligaments. So you can see I'm preserving the soft tissue envelope. I'm preserving the ligaments to close dead space. In the tip, I didn't remove anything cephalically, and I'm using a lateral crural steel. So that's preservation of the lateral crura. And the dorsum, I'm doing dorsal preservation. So it's a total preservation rhinoplasty. Nothing's being removed from this nose except for 1.5 millimeters of the caudal lateral crura. So again, this is just a review of the high subdorsal strip Saban technique, taking the high strip in the impaction. And this is 16 months postoperatively. And you can see that I've narrowed her tip, but I've also slightly widened her middle vault, which looks, to me, this looks like a much more balanced nose. We've gotten rid of her infralobular show. She's got good nostril symmetry. Her dorsum was beautiful before surgery. It's nice after surgery. You can see the dorsal hump is gone. She's got a much better rim highlight. And then laterally, you can see that I've decreased her nostril projection and increased her intrinsic projection while also having a very natural looking nose. Good smiling view. And then the basal view. So better symmetry in the nostrils. The second patient I'll show is another Latin patient who had a slightly different problem, which I think you'll appreciate. Okay. So this patient is the typical Latin patient that I see from the central part of Mexico. So she's got a low radix, S-shaped nasal bone. Do you see how those nasal bones are different than the last one?
Yeah, I can see that.
Yeah, so she's got a slightly underprojected tip and she's got wide nasal bones. So if you do dorsal preservation on this patient, a high or a low strip, you're most likely going to get a residual hump, low radix, and a dorsum that's too wide. If you combine that with a checker tip plasty in this patient, it's not going to work well. I mean, for me, it's better to take a balanced approach to augment the radix, do a cartilaginous push down by removing the bone cap and doing osteotomies and doing an extension graft to fix the tip in place. This is just showing a cranial tip suture. Cranial tip suture is placed. This, by the way, was invented by Milos Kovacevic from Hamburg. It's a very similar suture as a cephalic dome suture, but if you do a sub-SMAS dissection of the tip, this is almost a better suture because it's easier to modulate. It's easier to make it stronger or weaker. And again, I prefer this suture if you're doing a sub-SMAS or subdermal dissection. And it's a triangular stitch. Then I come slightly behind the existing bite and approximately 3 millimeters lateral coming out. Now you'll see what's really important in a Latin patient is you want to get real concavity of the lateral crura, and especially in the peridomal region with opening of that facet polygon. You need to do more aggressive suturing than you would on a thin-skinned patient because it's more difficult to see the definition. That's when I tie this suture. Sharpens the dome, tenses the lateral crura, and flares that caudal border. So you can see there the concavity I'm getting in the lateral crura. You wouldn't want to do this in a thin-skinned patient because then it would look concave. But in a Latin patient, they have thicker skin and that all fills in. Okay, let's see here. So just showing what the tip started like. Again, you see the short, medial, and middle crura, the lack of a facet polygon, The caudal border of the lateral crura is lower than the cephalic border, so you really want to rearrange the cartilage. You can see that the nose is tensioned centrally and laterally.
Yeah, so different.
Yeah, so if you look at what I did with the nose, I pushed down the cartilage, but I did formal osteotomies cephalically, which narrowed the bony pyramid. And then I got real definition in the tip and triangularity. And this patient's about 2.5 years out from surgery. So again, it was a cartilage high strip push down with osteotomies of the dorsum, and then an extension graft, cranial tip sutures, and a 2mm steel for the tip. You can see the smiling view, helicopter view. So look at how much better her dorsal aesthetic lines look cephalically.
Yeah.
So you can see where the radix graft and increase in tip projection help to balance the nose. And then a good basal view is still, you can still see a little bit of caudal septal foot plate deflection, but overall a better result.
Sure. I'm sorry, I don't know if I didn't listen to you. What kind of graft did you use on the radix there?
So when you're grafting the radix, you want something that's going to do 3 things. Number 1, you want it to not show, so it has to be soft. Number 2, you want to control the final result. And what I mean by that is you want to use something that's less likely to absorb over time. And number 3, you want to use something that's fairly easy to harvest in your same surgical field. The thing that in my mind achieves all of that is a dice cartilage and fascia graft for the radix. It's very easy to take a deep temporal fascia graft in about 10 minutes from here. I will finely dice about 0.05 cc's of cartilage, place it inside of the fascia and sew it into a ball and guide it out the nasal radix. That will feel soft. It's easy to harvest. And by putting dice cartilage inside, you know, whatever you see on the table, you'll probably get about 80% of that. If you just use deep temporal fascia, which I did for the first 3 or 4 years of my career, in some patients, it stays almost 100%, and in some patients, it goes away almost 100%, and on average, you get maybe 30 or 40%. So I went to dice cartilage and fascia, even for minor augmentations. I always put dice cartilage inside.
Okay, and how do you dice it very small, or just almost like a gel, or do you leave it a little bit bigger pieces?
You want to leave it a little bit bigger for the radix. And the reason is the bigger the pieces, kind of the more likely they are to survive. And the fascia wraps around it. But remember, the most important thing is this is very thick.
Yeah.
If you're doing dice cartilage on the rhinion, you want to make gel because you don't want it to show. But, you know, if you're grafting, for example, the super tip, you always want to use a solid graft because you know it's going to stay 100% and you're never going to be able to see or feel it, right? So I dice cartilage or use grafts based on tolerance for absorption and tolerance for how is this going to show over a 5 or 10 year period.
All right, great. And one very technical question, because I read on Dr. Roland Daniels' book about this, just like a ball of fascia, and you're saying that you put some cartilage inside, right? I also like always to put some diced cartilage inside, but sometimes I'm a little afraid of doing just a small piece on the top. Sometimes I tend to do a longer graft, but putting more cartilage on the top, you know, just like a tailor-made diced cartilage and fascia graft. So what you're saying that even if it's a small piece, you just put it, but the transition between this graft and the dorsum, sometimes do you have any kind of step or something like that?
About 4 years ago, I wrote a paper in facial plastic surgery, and it was on how to use the ultrasound in rhinoplasty. And one of the points I made was that I looked back over a 2-year period at all my revisions, and 50% of them came from dice cartilage and fascia grafts. And the answer is why. So first of all, a dice cartilage and fascia graft is like a solid graft. What you see on the table isn't necessarily what you're going to see at 2 years. And the reason is you have much thicker skin at the radix and the supratip, and you get a lot of swelling there during surgery. If you look at a nose that's straight on profile, under the skin, it has a hump. So if you have a nose that's straight and you put in a dice cartilage and fascia graft, 3 months later, you will have a hump. If you have a nose that looks scooped and you put in a dice cartilage and fascia graft, 3 months later, you'll have a straight nose. Next time you're watching anybody give a talk on dice cartilage and fascia grafts, every time they show a nose that's been over resected, the result will look beautiful. Every time they show any other nose, you will notice that the dorsum has either a slight hump at the rhinion or up a little higher in over 50% of their cases. And that's the reason why. So for me, unless I have to, meaning a patient has thin skin, over resected nose, I like to use dice cartilage and fascia radix grafts, but for example, in Asian patients, I use solid rib grafts. Dice cartilage and fascia is a beautiful technique, but the learning curve is very difficult, and you will have revisions, in my opinion.
Yeah, for sure. And one more question about the cartilaginous push down, right? It's would be similar, would be Ishida technique, right?
Well, Ishida, so you gotta. There's a lot of confusion about nomenclature. To me, Ishida technique just means that you are preserving the bone cap centrally and dropping the cartilaginous vault. Ishida does that with a high or a low strip. So,
Okay.
it's just what are you referring to, I guess, is my question.
Yeah, no, my question is another thing. When you release the lateral key area on cartilaginous push down, how far do you go down there? Do you go into the ligament, and do you release
So that's exactly the point. So if you're doing a high strip cartilage push down, okay. So I only do cartilage push downs if the hump is less than 3.5 millimeters. Because if it's bigger than that, you have to do a massive release. I also only very, very rarely do I do a low strip cartilage pushdown. Because again, if you do a cartilage pushdown with a low strip, you have to do a big lateral keystone release. The idea of dorsal preservation, in my opinion, is to take less apart and to make the operation simpler and more reliable. Once you start releasing the cartilage completely from the bone, this osteocartilaginous disarticulation, you're now really making your life more difficult, and you're opening yourself up to a lot of problems. So when I do Ishida technique or cartilage push down or spare roof technique, whatever you want to call it, I like to use the high strip. And the reason is you need to do minimal release of the lateral crura, and you can of the lateral keystone, and you can sew everything back down. That's just me personally. But, I do know that Valerio and Barish and Ishida, they like to do these low strip pushdowns or cartilage pushdowns. But for me, completely releasing the cartilage from the bone is just, it's a destructive thing to do. It's not preservation to me.
All right. And about the stability of your tips, you're seeing that most of your cases use septal extension. And how do you do that? Do you do a very small piece or a bigger piece, or do you put lateral contact with the caudal septum or end to end? How do you do that?
We're talking about in Latin patients?
Yes.
Yeah. So if I'm using a septal extension graft, it's usually for a reason, and it's because you really need to strengthen the chip and increase projection. So I use large grafts. That's another reason I like doing a cartilage pushdown, because you save all of your septal cartilage for structuring the tip. The only time I go side to side is when I laminate it. So if the caudal septum's here, I put a piece on this side and on this side to make what, like a taco around the caudal septum. Because if you put it on one side or another and then you pull the tip up, it's very easy for it to deviate to one side or another.
Yeah, I agree.
So either I laminate it around the caudal septum or I use an end-to-end graft. End-to-end, if the septum is straight, end-to-end is the best.
Okay, all right.
But also technically more challenging.
I'm sorry?
But also technically more difficult. And if I do end-to-end, then I always use extended spreader grafts up top and 2 bracing grafts down below. So I brace it in the middle with 4 grafts so that it can't shift. Does that make sense?
Yes. So you do like choose spreader grafts, long spreader grafts, and maybe choose levers.
Exactly.
All right. Sometimes do you use bone to stabilize it?
Only if I don't have enough cartilage, which is rare, but it happens, especially in Latin noses in women that are older. If they're over the age of 40, 50, sometimes they have very little septal cartilage, and then you're stuck.
Okay. And every time you, for example, you do high septal strip and you leave that cartilage and you leave an L shape, right? Is it the same L that you leave in open structure, or do you leave a little bit more cartilage there?
Whether I do structure or preservation, if I'm taking septal cartilage, I always leave at least 15 millimeters. And it's not a true L. It's more like this. Does that make sense?
Yeah. Yeah.
Yeah, I mean, so you want to leave more cartilage here and more cartilage here. And that's really where you get your real strength from.
Great, great. All right, so yeah, that's very, very nice. I think um, our our main difficulties in Latin noses are exactly this: how deal with this kind of thick skin patients and with cartilage, under projected tips, and how to stabilize it to have very nice results like you have. So I'm just gonna show you very briefly here some actually not exactly cases, but some concepts. All right, because many people that are watching us, they're starting preservation, and then we can go for discussion and questions. All right.
Yeah, just so you know, I'm looking at my computer. I don't have my charger. I have about 15 minutes left before my battery dies.
All right, so I'm going to be very quick here. Yeah. Okay, like we said before, can you see that?
Yep.
Can you see that? Yeah.
Yeah.
Yeah. Like I've been talking about preservation, and when we do structure rhinoplasty, pure structure rhinoplasty, we trust a lot on septal extension grafts, and that's not different when we talk about Latinosis, because as you said, maybe the best option is to really structure and give a good stability for the tip. But what I want to show for our audience is that we have many other things in the preservation rhinoplasty that now with the new concepts and understandings of anatomical studies, we have to pay attention. So that's septic extension grafts, but also ligaments, the scroll, posterior strut. So many things, including more limited dissection. So here just to show how strong is the Pitangui ligament. In some cases, you can use it for to make your suprateeth definition more defined. But as you said, in some Latinosis, you don't really need them, but it's also good to fixate them at the end of the surgery to give more, to give less dead space and better healing process in the post operation, so that you can see the traction on the supratip area. And also, you talk a lot about this. I'm just showing here some the concept of um, uh, let me the slide in technique. Oh, little problem here. Just a second. Yeah, can you see that?
Yeah.
Yeah, just the sliding technique where we can preserve the scroll ligament and the horizontal scroll, which I think it's also good in some cases. Um, Repairing the scroll ligament, a lot of people have a lot of questions about that. And this is interesting because I did in a secondary case, of course, but showing the concepts that Varis Shakir talked in his book, and also you talked about that um, when you were talking about the position of the dome and the lateral cruise steel. When you try to do a lot of lateral crude tensioning and lateral crude steel, in some cases you're not gaining actually projection, but you're gaining just rotation. Um, Let me just load the video here. Um, yeah, so yeah, video is stuck here, but actually, like you said, if here is a the dome and you start just doing rotation and lateral crude tensioning, probably you won't have just projection, you just gain rotation, and as you said, the nose will look won't look so good on this kind of patient. So I'm waiting for the next slide here, and I can show you on the iPad. Yeah, just a second here. Yeah, can you still see that? See that?
I can. Yep.
Yeah. Just a second here because my computer is stuck here. Yeah. Yeah, it's stuck here. While I just try to close this window here. Let's could you tell us a little bit about in some cases you said also about uh, some thick skin patients in Latin in how do you debulk, right? How do you debulk this? You do it open, and do you have a special technique to do that? I mean, do you? Some people use the dissection already on the subcutaneous tissue, and then they remove it. And some other people try to in a full open, they just pull part of the fat and they debulk that. How do you do that?
I think I have. I think I have a little video here.
Yeah.
Let me see. Hold on one second. Let me just see if this is what I think it is. So we've opened this nose, and there's absolutely no structure in the tip. Let me just take a look here. Everything that you're seeing is just this. Yeah. Do you want to share my screen?
Yeah. Just a second, please. Yeah, just a second. I'm here on a technical problem here with my keynote. Just a second. So I only see my image here. Is it stuck on the video, or can you see me?
Yours is stuck on the video.
Yeah.
Maybe it's a good place to stop then, because my battery's going to die in a couple minutes.
All right. So you don't have a charger there?
I don't. I forgot it at my house. I'm at my office.
Oh, really? Okay. Um,
Yeah.
yeah. So if you don't have a charger there, probably as you said, your computer is about to stop. Um, we won't have time to answer all the questions, right? But
Yeah, if you
um,
want to try and answer a few questions, I'm happy to.
yeah, let me see the questions there. Okay, how many minutes left do you have there?
Let's see. Probably about 5 to 10.
Okay. All right. All right. Let's go for some questions, Aaron, because this is really stuck here. Okay. Um, all right. First question here. How do you um, what differences do you see in a Latin nose on the table and 1 year after? What do you expect to change?
If it's structured properly, not a lot. If it's not structured properly, you're going to lose projection and rotation with loss of definition of the tip, widening of the nostrils, shortening of the medial and middle crura, and potentially, soft tissue, almost like a soft tissue polybeak formation. You got to structure it properly.
All right. And do you have experience with steroid injections, or you use just
You should only
oral
use
or
you should only use steroid injections if you're absolutely sure that you're injecting scar tissue. So I maybe do it 3 times a year, but I prove to myself it's scar tissue by ultrasounding the nose. When you ultrasound the nose, you should see dermis and subcutaneous tissue. But there are times that you will see scar tissue. And that's a third layer, that's the deepest layer. And so I'll inject that under direct vision. Otherwise, you're doing yourself a disservice, because if you inject into the dermis or into the subcutaneous tissue during the healing process, you don't know how that's going to affect things over time. So in primary rhinoplasty, maybe 3 times a year do I inject steroid.
all right, okay. And for very convex lateral crura, do you treat it with turning flap or lateral crura grafts? What do you do mostly?
Usually, if it's convexity, means it's too long. So if it's too long, you can scale and create a neodome to shorten your lateral crura. Other thing that will help is doing a slide under flap, because you're dissecting the mucosa off of the convexity of the lateral crura, and by sliding it underneath and suturing it, you're really sandwiching that area, which helps to stiffen, flatten, and strengthen the lateral crura.
All right, great. And when do you decide to do superchondral lower lateral crura dissection or subsmass?
I only do subperichondrial dissection if the patient has thin to medium skin or normal to strong cartilage, and a strut and ligaments are going to support the tip appropriately. But if I'm going to use an extension graft, unless the patient has thin to medium skin, I go subsmass. The only reason to go subperichondrial is to maintain thickness or to maintain ligaments. So if you're not trying to maintain thickness, or you're not trying to use the ligaments for support, the only thing it does for you is weaken the lateral crura, which can be a bad thing, especially in most Latin noses. Does that make sense?
Yes, yes. Um, yes, another question here. Do you feel swelling process in Latin patients is more often than in other kind of patients? And
Uh,
any recommendation for that?
I think that the swelling process in general can be a little bit longer if the skin thickness is greater, but if you tension the tip appropriately, the tip will actually look better than the rest of the nose faster. When I used to use columellar struts, it really used to take 9 to 12 months to really get that great tip definition. But if you tension the tip, if you push the tip against the skin enough, you'll see good tip definition at 1 month, even in a thick
Oh,
skin patient, even in an Asian patient.
great, great answer. Okay. Uh, in some Latin noses, do you consider to use only grafts on the tip?
No, because the tip is under so two things. The tip is under projected, and it's because the nostril projection, it's because the intrinsic projection is decreased, and there's too much bend of the infralobule. If you just pile grafts onto the nose, you'll end up getting a very long infralobule and not necessarily a better shape to the tip in the infralobule. So sometimes you do have to use a tip graft. But if you're using an extension graft, most of your increase in projection should come from that graft, and your tip graft is used for maybe a millimeter or two of projection, but really more to get definition. But if
All
you've
right.
ever done if you've ever done rhinoplasty in an Asian person, which is an extreme example of a Latin nose, if you just pile the tip with grafts, it just doesn't work very well.
All right. Do you have what's your percentage of recurrence or residual hump?
It's basically zero, and the reason is the first 150 dorsal preservations I did were a high strip in an open approach, using
Okay.
sutures in 3 or 4 areas to fixate the dorsum. So I never had a residual hump unless I was fooled by radix swelling, but I never had pop-up of the dorsum.
So you always fixate the dorsum with you do your holes with piezo, right?
Well, when I first started doing dorsal preservation, before I really understood how to flatten the dorsum and how to impact the nose, I would fixate the bones in one place and I would fixate the cartilage vault in 2 or 3 places.
Okay. And what kind of suture do you use?
4 PDS for the bones and 5 PDS for the cartilage.
All right. Okay. Maybe one last question here because you're running out of battery. How to approach Hispanic nose with thick skin that you want to decrease projection at the same time?
You need to convince the patient that that's a very bad idea.
All right.
If you don't do that, you're doomed to failure. It's not. In order to see tip definition, the reason. Okay, so the way that you see tip definition is your cartilage has to push against the soft tissue envelope to see defined polygons of the nose. So if you have thick skin and you decrease projection, how can you get the cartilage into a better shape and to push harder against the skin envelope? It's impossible. So the best you can hope for is to debulk the SMAS, and by some miracle, the skin is going to beautifully layer over your new cartilage shape. And that, for me, only happens in people with thin or medium to thin skin. In thick skin, it never happens. The nose just looks worse.
Yeah.
You know,
All right.
the other person that talks a lot about this is Arturo Regalado Breeze from Mexico. He operates in 100% Mexican patients his whole career. Every time, if you show him a patient and say, I want to deproject this nose, he'll say, don't do it. Convince them it's better to have a little bit larger nose with a beautiful shape than a small nose with no shape.
Great concept. All right, Aaron. Before your computer just shut down, I'd like to thank you again. All right, thank you again for your time and for all your talks and to show your cases. And I'm sure it was really helpful. And everybody who was watching us here, almost 400 people, they're gonna use these concepts on routine and do it on their
Thank you so
practice.
much for having me. I really appreciate it.
Yeah, thank you very much. And yes, hope to let's keep in touch. And in Latin America, there are so many good and very nice surgeons interested on this field of preservation rhinoplasty, especially with. But we have to know how to deal with our patients, right? Because the characteristics different from European patients. So thank you so much for all your concepts, okay?
Muito obrigado y muchas gracias.
All right. Okay, thank you so much, my friend. So,
Ciao.
bye bye. Ciao.